Transforaminal lumbar interbody fusion is a surgery for chronic low back pain due to intervertebral disc disease that is unresponsive to conservative options. These options include physical therapy, non-steroidal anti-inflammatory medications, and injections. The lumbar spine consists of 5 bones called vertebrae connecting the spine of the chest to the pelvis. The spine also houses and protects the nerves going to the legs. These bones are connected in the front by an intervertebral disc and in the back by 4 facet joints. The intervertebral disc contains a fibrocartilaginous nucleus. This nucleus allows movement between adjacent vertebrae. It is held in place by an annular ligament. The spine is further supported by a variety of other specialized ligaments. These structures allow forward and backward bending, bending to the side, and twisting. Over time, aging, trauma, and disease can lead to loss of resilience, thinning, and fragmentation of the disc nucleus. This can result in a loss of disc space with impingement of the vertebra and arthritis in the facet joints. The loss of disc height can lead to encroachment on the adjacent nerve roots. Pain can arise from the disc space, strain and arthritis on the facet joints, or spasm in the back muscles. Nerve root encroachment can lead to pain, numbness, and weakness in the legs. The day of surgery, you will arrive at the surgery center having had no food or drink since midnight the night before, NPO. In the preoperative holding area, you will receive an IV and medications to assist with anesthesia and surgery. An antiseptic body wipe will be carried out. You will be transferred to the operating room. A general anesthetic will be administered. You will then be placed prone or face down on a specialized operating table. Electrodes will be placed on your legs for neurophysiological monitoring to help prevent nerve injury during the operation. A portable fluoroscopic X-ray machine, commonly known as a C-arm, will be brought into the room to allow real-time X-rays of your spine during the surgery. Views from multiple angles can be obtained by positioning the C-arm. The surgical area will be prepared for surgery with an antiseptic solution. You will also be given antibiotics by vein. A sterile surgical drape will be used to isolate the sterile field. A sterile plastic drape will also be placed over the C-arm. A strict surgical environment over the surgical area will be maintained to minimize the risk of infection. Beneath the skin and subcutaneous tissue lies 3 layers of muscles overlying and attaching to the spine. The diseased area of the spine will be located and verified with X-ray. A small incision will be made over this area. A blunt probe will be used to locate the appropriate site for surgery and verified on X-ray. The hole will be enlarged with serial tissue dilators. Continuous neurophysiological monitoring helps to prevent nerve injury. Different types of drills and cutting instruments will be used to remove the majority of the damaged disc tissue. Removal is aided by irrigation and suction. Larger pieces are removed with grafting instruments similar to the cutters. Care is taken not to damage the annulus. Adequate removal will be verified with the use of a radiopaque dye that can be seen on X-ray. A synthetic fiber mesh structure, known as an optomesh, will be inserted into the disc space. Bone graft will be impacted into this mesh, expanding it and filling the disc space. Impaction force will re-expand the disc space. This serves to remove the nerve encroachment caused by the collapsed disc space. Metal screws and rods will be inserted to support the vertebra until the bone graft fuses with the adjacent vertebra. There is a column of bone connecting the front elements of the vertebra with the back elements. This column, or pedicle, passes between the adjacent nerve roots. A new incision for each screw will be made. The pedicle is located with X-ray using a blunt probe. The tissues are dilated and a drill is placed through the pedicle into the body of the vertebra. A specially designed pedicle screw is inserted into the vertebra. The process is repeated for 3 more screws. Each pair of screws on either side of the disc is then connected with a metal rod. The rod is secured to the screws with a locking screw. Screw guides are removed. Again, neurophysiological monitoring is used to help in prevention of nerve injury. After completion of the procedure, your incisions will be stapled and a sterile dressing applied. A local anesthetic solution will be injected to help with postoperative pain. Over the next 3 to 6 months, your body will gradually grow new bone into the graft, fusing or healing the two vertebrae into a single mass. X-rays will be obtained every 4 to 6 weeks after the initial 2-week follow-up visit to monitor healing. During this time, bending, lifting, and twisting will be limited. Tobacco use, poor nutrition, and non-compliance with activity limitations can all lead to delayed or failed fusion. The main complication of spinal fusion is residual low back pain. If you are 65 when you go into surgery, you will still be 65 afterwards. Obesity, arthritis, core muscle weakness, and general poor physical conditioning can all lead to back pain not amenable to surgery. Nerve irritation with numbness, burning, and tingling is common but usually temporary, lasting weeks to months. Permanent nerve damage, infection, and failed fusion are rare. In individuals who have the appropriate indications for surgery, the expectations are significant improvement in pain, but with a prolonged recovery time.